So, hi to all the viewers. Today, we will deal with a very important topic, that is MASLD. What are the new updates and how the approach, investigations, and management to this disease entity has changed over the last 2 to 3 years. Okay, so now you may think that hearing MASLD, which is the acronym for metabolic dysfunction associated steatotic liver disease. Steatotic liver disease. So this is a new terminology which has replaced the older term, which is NAFLD. So right from your MBBS days, you must have been hearing about the NAFLD, which was the non-alcoholic fatty liver disease. Now it has been replaced with MASLD, which is the metabolic dysfunction associated steatotic liver disease. Okay. So why, you may be thinking, this could be a core gastroenterology or hepatology topic, which is a liver disease basically. Why are we learning it under endocrinology? It's because this MASLD disease, it progresses as a spectrum, starts right from a simple steatosis, it can progress to steatohepatitis and finally cirrhosis. So once the cirrhosis sets in, the gastroenterologist or the hepatologist would take over. But then by that time, you would have very little to do to that patient rather than managing the complications and somehow trying your best to halt the progression. But the damage has already been done once the patient gets into cirrhosis. So the role is majorly played by a primary care physician or an endocrinologist who addresses the issue first, who is able to pick up the disease even before the fibrosis or the cirrhotic process has sets in. So this is one disease condition where prevention and halting the progression plays a paramount role rather than just waiting for the disease to set in and finally treating the complications. So that's why I have included this topic, because this is one of the emerging areas where lots and lots of researches with regards to the pathophysiology and the newer molecules which can improve the condition is coming even on a monthly basis. If you just search the literature for the drugs which are on the pipeline for managing non-alcoholic steatohepatitis, you can see dozens of them. So such is the interest in the research with regards to the MASLD and steatohepatitis. So with this introduction, I would move straight into the topic. Okay, so why is it important to learn about non-alcoholic fatty liver disease, which was the previous terminology of metabolic dysfunction associated steatotic liver disease? One important point would be the growing incidence. Okay, now as the name suggests, it is associated with metabolic dysfunction. Okay, the metabolic profile is altered. There is a worldwide pandemic of obesity where the patient is increasingly having excessive visceral adiposity, excessive insulin resistance, and consequent fatty liver. So this would obviously result in the increasing incidence of NAFLD. And in the Western countries, in individuals more than 65 years, this NASH-related cirrhosis is the leading cause for liver transplantation, leading cause for transplantation. in more than 65 years in both sex. Whereas in females, even in those less than 65 years, it has already become the most common cause for a liver transplantation, surpassing the alcoholic liver disease, hepatitis C infection, etc. And this is the liver disease which has the fastest growth rate with regards to the incidence. So this is going to be a global health problem if it has not already become one. Okay, now what are the liver consequences of a simple fatty liver or a steatotic liver disease? You may see the finding of fatty liver in one of the ultrasound or the CT or an MRI, which could be done for some other reason. What are the consequences that the patient may have? It can progress right from a simple fatty liver to inflammation and cell death, which you call as steatohepatitis. And this steatohepatitis can further progress to cirrhosis, which can decompensate, or it can again lead to cirrhosis, which could progress to hepatocellular carcinoma. So this is the natural course of progression. Not all fatty liver cases progress to steatohepatitis. Not all steatohepatitis would progress to cirrhosis or hepatocellular carcinoma. There are certain underlying risk factors, both genetic, environmental, and certain epigenetic factors that can determine the progression of the fatty liver to the end stage complications. And last but not the least, this is one very severe and serious disorder which can be effectively prevented, or if you are able to identify at its early stages, you may even be able to reverse the condition. So this has got adverse health consequences of paramount importance which can potentially be treated and reversed. So that is the importance of learning about NAFLD, or which we call as MASLD. Okay, so starting with why this terminology has been changed from NAFLD to MASLD. One, of course, to reverse the or remove the stigma associated with fatty liver. Okay, uh, the patient is being told to have a fatty liver could be associated with some sort of stigma, and that doesn't really reflect the exact pathophysiology that is leading on to the condition. That is why that terminology fatty liver was changed. And because it is not just fat deposition alone, there are so many factors which are playing in conjunction to eventually result in the fatty liver disease or steatotic liver disease. And of course, one major drawback or limitation that existed with the previous classification of NAFLD was that you have this was basically a disease of exclusion. You wanted to exclude all the possible liver disease etiologies like the alcoholic liver disease, all other autoimmune hepatitis, viral infection related liver disease. Everything has to be excluded before we can finally reach the diagnosis of NAFLD. And what if the patient who already had an alcoholic liver disease, he or she could still have a component of NAFLD also, because all these metabolic derangements can also accelerate the progression of liver disease. So in previous classification, there was no provision where a patient can have a coexistent alcoholic and a non-alcoholic fatty liver disease. So with the advent of the new classification, you can include those diverse etiology where partly it could be contributed by the metabolic dysfunction associated steatotic liver disease, partly it could be contributed by other etiologies, be it alcoholic liver disease, viral hepatitis related cirrhosis, or Wilson disease, whatever. Okay. And more importantly, you are having a generalized nomenclature so that it would facilitate the new research and a real world inclusion. Such consensus in the definition is very important, which was lacking previously. There was no universally accepted definition for NAFLD previously, but now they have defined specific categories and has given operational definitions so that would bring about a generalization when it comes to research and further investigations are concerned. Okay. So with this, we are moving on to the topic proper. And here I would not be dwelling too much into the theoretical aspect. I will not be dealing about the pathophysiology, the risk factors, the genetics and all that. I'll be mainly focusing on what is to be done from a practical point of view to identify, evaluate, and treat a patient with suspected or confirmed MASLD. So that would be the sole aim of this class, not to dwell too much into the theoretical aspect. Okay. So this is the current classification spectrum of steatotic liver disease. Now, steatotic liver disease, as I've told, is the new terminology to denote the fatty liver disease. Okay. So when you incidentally identify a fatty infiltration of the liver, you call the condition to be steatotic liver disease. This fatty deposition in the liver could be due to so many causes. And our area of focus in today's session is the MASLD, which is the metabolic dysfunction associated steatotic liver disease. But that is not the sole cause for fatty infiltration. You have ALD, which is the alcoholic liver disease. Okay, alcoholic liver disease. You have MET ALD. MET ALD means in a patient with basically alcoholic liver disease, on top of that, he or she is having metabolic risk factors. We'll be seeing in a short while what are those metabolic risk factors. So this is one advantage with the new classification. A patient could have a coexistence of two diverse etiologies and you still have a specific criteria or category to include such patients. So basically an alcoholic liver disease patient who is also having metabolic risk factors. Now, when do you call the patient to be having alcoholic liver disease? It is when you have documented the liver disease and you also get the history of significant alcohol consumption. You know, what is significant alcohol consumption? The criteria varies, but the most prominent criteria given in the AASLD and INASL guidelines for India and US respectively, they tell that when the alcohol consumption is more than 20 grams per day in females and more than 30 grams per day in males, you call it to be significant. So if such alcohol use criteria is identified, then definitely alcoholic liver disease would be the possible etiology. And on top of that, the patient is also having metabolic risk factors. You call the patient to be having MET ALD. Okay. And 1 gram of alcohol, according to the UK standard, 8 grams of alcohol is equal to 1 unit, according to the United Kingdom standards. It may slightly vary in the US standard. Okay, so but this is the one that is predominantly given in the guidelines. Okay, now we have learned about the spectrum of steatotic liver disease. So other etiologies, we will be learning in a short while what are the other possible conditions that can result in a steatotic liver disease. And finally, if you search for all etiologies and none of those are turning out positive, you call it as cryptogenic steatotic liver disease. Okay. So now we are moving on to the diagnostic criteria of MASLD or MAFLD. Okay, MASLD is the current terminology. Now, under 3 circumstances, you can diagnose that the patient is having MASLD. One, of course, the baseline criteria would be the presence of fatty liver or steatotic infiltration. Now here, we are going to define the metabolic dysfunction part. In this slide, we are telling how are we quantifying the metabolic dysfunction. So you call the patient to be having metabolic dysfunction if one, the patient is obese. If the patient is obese, what is the criteria for telling obesity in an Asian person? It is BMI more than 25 in Asians. So to tell that's overweight, it is 23. So 23 kilogram per meter square in Asians is overweight and more than 25 kilogram per meter square is obese in Asians. So overweight or obese criteria, if it is satisfied, then that is one a thing to tell that the patient is having metabolic dysfunction. Second, if the patient is already a diagnosed case of type 2 diabetes. Third, if the patient is a non-diabetic, non-obese person, but has certain metabolic risk factors. That is the presence of at least two of the metabolic risk. And what are the points listed under the metabolic risk criteria? It is exactly the same as that of metabolic syndrome criteria with two additional points. Okay, two additional points including the HOMA-IR and the high sensitivity CRP level. So this is basically what we have already learned under the metabolic syndrome criteria, like the waist circumference of more than 90 centimeter in males and 80 centimeter in females, blood pressure of more than 130/85, plasma triglyceride of more than 150, HDL less than 40 for men and 50 for women, and the presence of pre-diabetes as evidenced by fasting glucose more than 100 milligram per deciliter or 2-hour post-load more than 140. So in addition, so these are the criteria for metabolic syndrome, as you all know. So apart from that, you can include two other pointers also, like the HOMA-IR that you calculate using the fasting glucose and fasting insulin if it is more than 2.5, or the high sensitivity CRP level if it is more than 2 milligram per liter. Then also you can say that the patient is having metabolic risk factor. So two of them need to be positive along with the fatty liver documentation to tell that the patient is having metabolic dysfunction associated steatotic liver disease. Okay, so moving on to the definitions. So MASLD, you want steatosis plus either of type 2 diabetes or obesity or two metabolic risk factors. So this is how you diagnose MASLD. And of course, it is needless to say that you have to rule out other causes. Rule out other causes. Now, how do you define steatosis? That is another question. How do you define steatosis? So steatosis is said to be present if more than 5% of hepatocytes have macrovesicular fat. So this can be a potential, if you are appearing for the NEET SS or INISS, this could be one of the MCQ points. More than 5% of hepatocytes should have macrovesicular fat to tell that he or she is having steatosis. So presence of steatosis plus the risk factors that we have already learned, and of course, ruling out other causes. This is when you call the patient is having MASLD. Now, you might have heard about NASH previously, but now the current terminology is MASH, metabolic dysfunction associated steatohepatitis. Metabolic dysfunction associated steatohepatitis. Okay. So to call the patient as having MASH, you have to have three factors. One, of course, steatosis. That means more than 5% hepatocytes with fat, plus lobular inflammation, plus hepatocyte death as evidenced by ballooning. So you can obviously say that this is predominantly a histological diagnosis. So the actual NASH diagnosis is histological, where you have to document this steatosis, lobular inflammation, and ballooning. But of course, there are certain surrogate markers to identify this lobular inflammation and ballooning, which we will learn in due course of time. Okay. Now, the next is MET-ALD. MET-ALD we have already learned, where the patient is basically an alcoholic liver disease plus metabolic dysfunction. The criteria for metabolic dysfunction you have already learned, either obesity or type 2 diabetes or two of the metabolic risk factors. Then you have alcoholic liver disease, which we have already defined, where the patient has evidence of liver disease plus significant alcohol consumption as evidenced by more than 20 grams of alcohol per day consumption in women and more than 30 grams per day consumption in men. Okay, so this, I hope it is clear for you regarding the basic definitions of MASLD, MASH, MET-ALD, and ALD. Okay, so moving on to the next part, a basic idea regarding the prevalence of MASLD and MASH. Okay, so steatotic liver disease in obesity, it is extremely common, and as the BMI increases, the prevalence also increases. So you can safely say that even in general population, you don't specifically look at diabetic or obesity. If you randomly take 100 people from the from your society, around 20 to 30 would have MASLD. So such high, the prevalence of MASLD is in such high proportions nowadays. Okay, so even 20 to 30% would have steatosis, and in obesity, it is definitely more than 70%. And when BMI is more than 30 to 35, almost 100% would have steatotic liver disease. And in type 2 diabetes, it is around 60 to 70%. Now, occurrence of MASH in MASLD. So once the patient develops steatotic liver disease, I told you, all of them won't progress to steatohepatitis. Around 20 to 25% MASLD would progress to MASH. And around 10 to 15 percentage 10 to 15 percentage of MASH would progress to cirrhosis. But because the population prevalence of MASLD is very high, this would still be a big and considerable number. So that amounts to the public health problem that is contributed by the MASLD. So as much as 30% of the general population is having MASLD, 70% of the diabetic, and almost 100% of the ones with severe obesity. And 20 to 25% of MASLD would progress to NASH, and around 10% of NASH would progress to cirrhosis. Okay. So diagnostic principles in MASLD we have already learned. Just a brief recap. One, you have to document steatosis, that is more than 5% hepatocytes should have fatty infiltration. Either we have to do confirm it by histology or by imaging. Second, absence of significant alcohol intake. We have already seen the definitions. No other competing cause for hepatic steatosis, and of course, no other causes for chronic liver disease. Only if these four diagnostic criteria are met, you can safely make a diagnosis of MASLD. Okay, along with the features of metabolic dysfunction. So when you see fatty liver being identified in a patient, of course, the two most important causes would be an alcoholic liver disease and a MASLD. But of course, you have to think of certain rare conditions which can result in steatosis, like a hypo-beta lipoproteinemia, acid lipase deficiency, certain nutrient deficiencies, Wilson disease, celiac disease, certain viral hepatitis. So all these are rare possibilities. I'm not going into the individual attributes of each diseases, but this is just to emphasize that all causes, all fatty liver identified cannot be attributed to MASLD or alcoholic liver disease. Once in a while, a rare cause could also present with steatosis in such patients. So that is why the initial evaluation becomes all the more important, because your history, physical examination, and the basic investigations should have the parameters to rule out these diseases as well. And very important to take a proper drug history in these patients. Because if the patient is on long-term medications, for example, with amiodarone, tamoxifen, methotrexate, and even glucocorticoids, they can result in steatotic liver disease and can mimic. And for example, a patient taking corticosteroids, they can have secondary metabolic dysfunction associated with steatotic liver disease. So that is not basically MASLD, but rather a corticosteroid-induced metabolic dysfunction plus steatotic liver disease. So taking a prudent drug history is very important while evaluating a patient with suspected MASLD. Okay, now looking at more of the practical aspects. You are sitting in a clinic, a patient is coming to you. Should you screen MASLD or the presence of NASH in all such patients, or are there any specific criteria for eligibility for MASLD screening. So do you need to screen MASLD in general population? There is no recommendation. There is no recommendation to screen for MASLD in general public. So, which are those high risk categories where you should perform MASLD screening even during routine visits? One or two we have already discussed. Patients with type 2 diabetes. Time and again, you should make them undergo NASLD screening by doing appropriate test. Okay. Then patients with obesity. Okay. Patients with obesity. Third, patients with raised transaminases. AST or ALT. Of course, you should look at the alternative possibilities for raised transaminases also, but you should not also forget about MASLD MASH. And fourth, a patient with incidentally detected steatosis. So by and large, these are the four major indications for screening for the presence of MASLD. One, type 2 diabetes, obesity, transaminitis, and four, incidentally detected steatosis. The patient would be undergoing an ultrasound abdomen for a non-specific abdominal pain, but incidentally he or she would be diagnosed with fatty liver. Then you should evaluate for the presence of MASLD. Okay. So this is about the initial evaluation of MAFLD or MASLD, which we have already discussed. You have to look at the history. The major focus would be to identify any possible alternative diagnosis, to look for medications, then look at the metabolic risk factors like family history of diabetes, NAFLD, cirrhosis, then other factors like OSA, alcohol use, etc. And physical examination also, you should be looking at whether the features of established cirrhosis, portal hypertension is there, other features of alternative etiologies for liver disease is there, such things. And laboratory test also, you should look at the basic metabolic profile like fasting plasma glucose, HbA1c, lipid profile, creatinine, and other issues. Then viral hepatitis screening. Then for if needed, or if there are any clues for any underlying liver disease, you can look for the autoimmune hepatitis screening. Then the transferrin saturation for hemochromatosis, ceruloplasmin for Wilson disease, alpha-1 antitrypsin levels, and genotype for alpha-1 antitrypsin deficiency, etc. Okay, so such things are not done as first line, but if certain contributory or suggestive findings are there, then definitely you will have to go to such extent so as to rule out those conditions. Okay, now looking at very, very important practical points. How are we specifically going to assess a patient with suspected MASLD? Okay, so the cornerstone of diagnosis of steatotic liver disease is first to detect the steatosis. We have to document that steatosis is present. Then we will have to see whether it is just steatosis or steatohepatitis. Steatohepatitis means on top of fatty infiltration, you also have lobular inflammation and uh, ballooning, that is hepatocyte cell death. And once the steatohepatitis sets in, you know that a certain proportion of such individuals would go for fibrosis. So initial fibrosis would be like perisinusoidal or lobular fibrosis, and later on it would lead on to bridging fibrosis and established cirrhosis. So at any cost, you want to identify those patients before they go into advanced fibrosis and cirrhosis. You have to detect them at possible even before the onset of steatosis, but at least before the patient is moving on to advanced fibrosis. So either at the level of steatosis or even steatohepatitis or early fibrosis, you will have to identify the patients so that we can institute the measures to further prevent the progression of fibrosis and cirrhosis. Okay, then you will have to look for the presence of fibrosis and finally detect the cirrhosis. So the gold standard for each of these steps for documentation of steatosis, steatohepatitis, fibrosis, cirrhosis. So the gold standard for this is always histopathology. So histopathology is the gold standard. But the issue is you cannot just do liver biopsy in all such patients to identify each stage of the disease. So that is not a practically feasible option. So you'll have to resort to other non-invasive modalities to identify each of these steps. Okay, so that is the primary focus of today's session. Now, how are we going to assess steatosis in such patients? Okay, so steatosis is most commonly assessed with the help of ultrasound abdomen. USG abdomen is the most commonly done investigation to look for the presence of fatty infiltration. Then you don't usually use CT abdomen or MRI abdomen straight away to assess steatosis, but you may do a CT or an MRI for some other unrelated conditions, but incidentally they would pick up fatty infiltration. So CT and MRI can also document the fatty infiltration in the liver, but those are not the primary modalities that you resort to. Then there is something called as a controlled attenuation parameter. I hope all of you have heard about something called as a fibroscan, the details of which we will learn in the coming slides. So there is something called as a fibroscan. Okay, fibroscan, which is nothing but that is a commercially available form of fibroscan, which is basically ultrasound-based elastography. So elastography means you are using ultrasonographic waves to look at the elasticity or stiffness. You know what happens with when there is fatty infiltration is that there is a change in the texture of normal liver. You know, normal liver has a certain echogenicity and certain texture. When there is steatosis and further steatohepatitis and fibrosis, the texture changes. So the speed of the wave that is emitted from the transducer is also altered when there is a change in the texture of the liver surface. So you are looking at the change in the texture to identify the fatty infiltration as well as the amount of stiffness and fibrosis. That is the principle of ultrasound-based elastographic techniques, and one of the example is fibroscan. So with the help of fibroscan, you can assess both the steatosis as well as the liver stiffness or fibrosis. Both can be assessed by a fibroscan. So that again, this is one parameter, controlled attenuation parameter, which is abbreviated as CAP. This is one parameter that can be assessed with the help of fibroscan. So if in any fibroscan report, if you see something called as a CAP, you have to learn that that is a surrogate measure of the extent of steatosis within the liver. Okay. Then you have finally MRI based fat assessment, where you use a specific gradient echo sequence, a specific sequence of the MRI that specifically looks into the fat infiltration in the liver. It is called as the proton density fat fraction, PDFF. Okay. So basically, ultrasound abdomen, fibroscan, and MRI, that too not the regular T1 and T2 weighted MRI, the gradient echo sequence where you look at the proton density fat fraction. Okay, so these three are the usually employed methodologies with which you can document the steatosis. Okay, so in ultrasound abdomen, all of you must have seen the reports coming as grade 1, grade 2, grade 3 fatty liver, etc. So grade 1 means there is a diffuse increase in the fine echoes in the hepatic parenchyma, but the visualization of the intrahepatic vessels and diaphragm is not altered. So only the hepatic echogenicity is having an alteration, but there is no difficulty in visualization of the diaphragm or intrahepatic vessels. Whereas grade 2 means there is a slightly more increase in the echogenicity and there is a slightly difficulty in visualization of the intrahepatic vessels and diaphragm. And grade 3 means you are not able to exactly make out the borders, the vessel borders, the diaphragm, the posterior portion of the right lobe of the liver, etc. So it is basically this classification of grade 1, 2, 3 is a only not a exactly objective finding. It has a subjective element to that. That is why two ultrasound done very few days apart, only a few days apart, would show one having grade 2, one having grade 3 fatty liver. It is not actually such a rapid progression. It is the change in the subjective interpretation by the radiologist. Okay, so grade 2 means the vessel borders and diaphragm borders can be made out, but it is not as clear. Whereas in grade 3, they are obscured and you cannot exactly make out those borders. Okay. So the problem with ultrasound is that this is not very sensitive, not sensitive for steatosis. Why did I say is that, to say that the patient is having a steatotic liver disease, only 5% of the hepatocytes need to be laden with fat. But the ultrasound shows at least grade 1 fatty liver only when around 20 to 25% hepatocytes have fat within that. So when there is a 10% or 15% hepatocytes are having fat, that may not be readily evident in the ultrasound. So that is why you tell that the ultrasound abdomen is not a very sensitive investigation for detecting very milder amounts of steatosis. Okay, looking at the controlled attenuation parameter, this is a parameter which is obtained from the fibroscan that we have already learned. So this is based on transient elastography. So what are the types of elastography and all we will learn in the coming slides. Okay, so this is one of the parameter that you get from the fibroscan, and the unit for expression is decibel per meter. Okay, decibel per meter. And the normal measuring range is between 100 to 400. So as the controlled attenuation parameter increases, the degree of steatosis is also increased. So the cutoff for, say, grade 1, grade 2, and grade 3, you have different cutoffs, but these are not universally standardized. So if you look at the different research papers, you can see different cutoffs. And even the guidelines don't specify a definite cutoff to tell that above this is grade 1, above this is grade 2, above this is grade 3, like that. So arbitrarily, you can say that around more than 240 decibel per meter is grade 1, around 265 to 270 is grade 2, and more than 285 to 290 is grade 3. So this is not an exact cutoff, but it will give you an idea. So if the value is less than 240, then well and good. You can say that there is no significant steatosis, not even grade 1 steatosis. Whereas if the control attenuation parameter gives a value more than 300, then you can be sure that there is some severe, significant degree of steatosis. So it again gives you almost a semi-quantitative assessment regarding the steatotic pattern of the liver. So now moving on to proton density fat fraction, you can see that here, to call that the patient is having steatosis, the value has to be more than 5%. Okay, this 5% cutoff is used in this proton density fat fraction cutoff MRI. So when the fat content is not there, the liver would appear more blackish in color. So this liver has a PDF of coefficient of 1.2%. That means there is no fatty liver. Then you can see that darkness is slightly fading. You can see 7.8. So here the cutoff of that 5% has been crossed and the patient is having steatosis. Then as the percentage increases, you can see the brightening up of liver in the images. And here it is more than 20 and it signifies severe or moderate to severe fatty liver disease. So in proton density fat fraction also 5% cutoff is used, and higher the steatotic component, more bright would it appear in the images. Okay, this is one HEPA fat scan, which is a commercially available scan, which specifically looks at the fatty content in the different parts of the liver. Here also the cutoff is the same. You can see this patient who has undergone this HEPA fat scan has a fraction of fat more than 24.9%. This patient at a different section has a cutoff of 18 point, as a fat content of 18.6, which both are above the cutoff of 5%. Okay, so 5% is the cutoff that we use in MRI based imaging. And regarding ultrasound based elastography, the fibroscan and all, we have seen the cutoffs for controlled attenuation parameter. Okay, now assessment of steatohepatitis, as I've told you, the gold standard for assessment is always histology. Okay, histology is the gold standard for steatohepatitis assessment. And this is the score that we use, which we call as the NAS, or the non-alcoholic steatohepatitis activity score. So this is not done routinely because it requires a biopsy. So there you are looking at the degree of steatosis, and based on that you are classifying it into mild, moderate, and severe, depending on what percentage of hepatocytes are involved. Less than 5%, you call it as no steatosis. 5 to 33% mild, 33 to 66% moderate, more than 66 it is severe. Then apart from steatosis, you also look at the lobular inflammation and you have a scoring for that also. Then you look at the ballooning, and finally you look at the fibrosis classification. Fibrosis is classified from F0 to F4. F0 is no fibrosis. F1 is perisinusoidal or periportal. F2 is perisinusoidal plus periportal. F3 is bridging fibrosis, and F4 is cirrhosis. So from F2 onwards, you will say the patient is having an advanced fibrosis. F0 and F1 is no and mild fibrosis. F2 is onwards advanced fibrosis. So F2 and F3 is advanced fibrosis, and F4 is established cirrhosis. So you take into account all these parameters and count the individual points. And if it is more than or equal to 5, you make a diagnosis of NASH. So this is how, in an ideal scenario, you should make a diagnosis of NASH. But practical point of view, you don't resort to liver biopsy unless you have certain diagnostic confusion and certain confounding factors that you are not able to reach at a proper diagnosis. So only in such situations, you would go for the biopsy to establish the diagnosis of non-alcoholic steatohepatitis. Okay, so we have learned about steatosis, we have learned about steatohepatitis. Now looking at the most important part, I would say, which is detection of fibrosis or advanced fibrosis. Because this is where you will have to keep your maximum attention to, because this is a point of no return. Once the patient has crossed the path of advanced fibrosis, then he's on the path to cirrhosis and you cannot reverse it back. But if you are able to identify that state of early fibrosis or on the brink of advanced fibrosis, then you can institute certain remedial measures to bring down these fibrotic changes. So to know whether the patient has features of early fibrosis or is going on to advanced fibrosis is extremely important. And I would say this is the most important step in the evaluation of a patient with MA-SLD. So detection of advanced fibrosis or any fibrosis for that matter, definitive, I've told you, it is histopathology. So definitive is histopathology, but that is not feasible in a large share of patients. By doing a histopathology, getting a good enough liver biopsy specimen, you can classify it as F0, F1, F2, F3, or F4. But that is not possible in a large number of patients. So you have certain other surrogate markers for fibrosis, which can either be a serum-based calculations, then imaging-based test, and you have tests that combine the serum plus imaging. Now, which are the biomarker-based tests? So the two important biomarker-based tests I would tell would be FIB4, which is the fibrosis 4, ELF, which is the enhanced liver fibrosis panel. And this is the currently the two most validated serum biomarker-based non-invasive tests to assess the degree of fibrosis in a patient with MASLD. And you have so many others also which has been historically used and now also being tried out. New and new scorings have been coming out in the last decade or so. And one thing which has previously been used historically was APRI. We will learn about that. Okay. So FIB4 and ELF are the two most important ones, I would say. Then the imaging based test, you have two major imaging based tests. Of course, one is the ultrasound elastography. I've told you by using the elastographic techniques, you can assess not only the steatosis, but also fibrosis. Then second would be the magnetic resonance elastography. So two elastographic techniques you assess to surrogately measure the fibrosis. They are ultrasound-based elastography and magnetic resonance elastography. Then you have the combination of serum test and imaging test, which we will also learn. Okay. So looking at the most important and the most practically feasible alternative for fibrosis, which is the FIB4 score. So this is one thing that you can easily do in your outpatient sitting where you are first seeing the patient. So originally, this FIB4 was introduced in patients with HIV plus HCV co-infection and to assess the liver fibrosis. This was first devised in that group of patients and was later it was identified that it can be generalized to other forms of liver fibrosis as well. So components, what all parameters do you need to calculate FIB4 score? You need the patient's age, you need the patient's platelet count, then you need patient's AST or SGOT, then ALT or SGPT. So these are the things that you need to calculate the FIB4 score. And it is used in whom? All the patients where you suspect MASLD, like in type 2 diabetes patients, in patients with obesity, patients with metabolic risk factors, and the patients with raised SGOT-PT. So all these patients, you have to calculate the FIB4 score to get an idea regarding the possibility of underlying fibrosis. Okay, so this is how you calculate the FIB4 index. In the OPD, you need not do the multiplication, division, square root, and all. You have online calculators. Online calculators which are dedicated for FIB4. You can use it as a free online tool, or there are free medical calculators. For example, you have something called as an MD Calc, which is perhaps the most widely used medical calculator, which is can freely be downloaded from both the Play Store as well as from the App Store. So just by selecting the FIB4 index in those calculator and entering the values, you will get a output for the FIB4 index. And this is how the actual formula goes. Age into AST divided by platelet count into root of ALT. Okay. And two important points regarding FIB4 score. It should not be used in individuals aged less than 35 years. And it cannot be used in patients with acute liver disease. In patients with acute liver disease, you will have a disproportionate increase in SGOT, SGPT, which will confound your results. So acute on chronic liver disease, as well as in a purely acute disease, you cannot use FIB4 index to assess the degree of fibrosis because it will give a false wrong value. It will give a wrong value. Okay, so these are the two fallacies of FIB4 score. It cannot use in very young individual, and you cannot use in acute decompensated liver disease as well. Okay, now we are looking at the cutoffs and how you should employ FIB4 in your clinical practice. So we have already learned that if the individual is having an age less than 35 years, you should not use FIB4 scoring and you should resort to alternate fibrosis assessment method. Okay, so less than 35 years, there is no utility for FIB4. There may be utility, but as of now, it has not been validated for use. And this is your business age group where most of your patients would lie. And these are the threshold. So by calculating the FIB4 score, you can just see that. So platelet count comes in the denominator and AST comes in the numerator. So it is obvious that in patients who are having advanced fibrosis or evolving into cirrhosis what will happen to the platelet count due to hypersplenism and sequestration and all? They would have reduced platelet count. And as the fibrosis sets in, they would have increased AST as well. So we are sure that in patients with advanced liver disease or cirrhosis, the platelet count goes down and the AST would go up. So what will happen to the FIB4 index? Obviously, FIB4 would also go up. So that is why high FIB4 more than 2.67, it tells you that advanced fibrosis is likely. Okay, so more than 2.67 means advanced fibrosis is likely. Whereas in a diabetic patient, if the FIB4 is less than 1.3, then we are fairly safe. We are reasonably sure that there is no significant fibrosis in this patient, and you can just ask the patient to leave and follow after, say, 1 to 1.5 or 2 years. So that is the importance. Less than 1.3, there is no significant fibrosis. More than 2.67, advanced fibrosis is likely. And you should immediately refer the patient to a gastroenterologist because there is high chance that the cirrhosis has already set in. He or she may have features of portal hypertension and has a multiple things to be addressed. Whereas if the value is between 1.3 and 2.67, then he may or may not have advanced fibrosis and more tests are required. Okay, so this 1.3 is the lower cutoff and 2.67 is the higher cutoff. More than 2.67, you are in a very dangerous place. The patient is likely to have very advanced fibrosis. And in patients with age more than 65 years, you expect some degree of stiffness as a proportion of age. It may not be part of the MASLD, but as a proportion of age, they may have some inherent stiffness. So we'll have to use a higher cutoff. So in more than 65-year-old, even if the FIB4 is up to 2, then it is safe. So instead of the 1.3 cutoff used in age 36 to 64, if the individual is more than 65 years old, you use the cutoff of 2. And the upper limit of 2.67 remains the same. So the 2.67 cutoff remains the same, whereas the lower limit is increased from 1.3 to 2 in individuals more than 65 years. So this is very, very important. So if I ask you to take one take-home message after this session, it would be to regularize the use of FIB4 index in a outpatient diabetic or obese patient that you see. Because if you identify a fibrosis at an earlier stage, whatever intervention you do, it may help the patient and will halt the progression, will help the patient to halt the progression to advanced forms of liver disease. So you may be able to save one patient going into cirrhosis progression. Okay. So we have learned about the FIB4 panel, where is it used, where it should not be used, what are the cutoff, and how do you approach as per the cutoff. The second, and something which is considered more specific than FIB4 in ruling in and ruling out cirrhosis, is ELF. So ELF is Enhanced Liver Fibrosis Panel. Enhanced Liver Fibrosis Panel. So what is basically being done here is that in a patient with NASH, there is definite inflammation. Okay, so the two cardinal features in a patient with MASLD and MASH is one, there is fatty deposition or lipid droplet accumulation along with inflammation and fibrosis. So lipid deposition, inflammation, and fibrosis are the two or three characteristic abnormalities occurring in a patient with MASH, MASLD. Okay, so in such patients, there will be increase in the levels of biomarkers that correlate with the fibrosis. So when a fibrotic process is happening in our body, the byproducts of this fibrotic process would also be raised in the circulation. So in the ELF panel, we are looking at such 3 biomarkers of fibrosis. They include serum hyaluronic acid is one. Hyaluronic acid is one. Then you have the N-terminal propeptide of collagen type 3. Type 3 collagen. So N-terminal propeptide of the type 3 procollagen you have, and you have the uh, tissue inhibitor, tissue inhibitor of matrix metalloproteinase 1, or we call as TIM1. So these three you can do together as a panel, and of course it is available in India, and it would cost around say 4,000 to 4,500 rupees in India, and this has got a good positive predictive value. Okay, and the cutoff we tell is that if the value comes back as less than 7.7, based on these three values, you incorporate it into some sort of formula to get the final output. So if you just ask for ELF panel, they would measure the serum levels of these three metabolites, and they would incorporate the final the values that they get into a formula, and you will get the ELF cutoff as a numerical value. If it is less than say 7.7, then no fibrosis. If it is more than 9.8, there is significant or advanced fibrosis. And if it is in between that, again, you are in the soup. You cannot determine whether the patient is completely fibrosis free or is having some degree of fibrosis. So this has a good negative and positive predictive value. If it is less than 7.7 and more than 9.8, you can be fairly sure of what the outcome the patient is having. So far we have learned about two things. One is the FIB4 index, and second is the ELF panel, which makes use of the three serum biomarkers, which are markers of fibrosis in our body. Okay, serum hyaluronic acid, N-terminal propeptide of type 3 collagen, and 3 is the tissue inhibitor of matrix metalloproteinase 1. Okay. So then you have something called as APRI. APRI is AST, or aspartate aminotransferase to platelet ratio index. So this is calculated by AST in the patient divided by AST normal value in that reference range divided by platelet count in 10 raised to 6 value. Okay. So this is the formula. This has been found not to have excellent correlation, but somewhat moderate correlation with regards to fibrosis. And this APRI has been superseded by the newer ones like the FIB4 score and the enhanced liver fibrosis panel. Okay, so the cutoff says that if the cutoff is more than 1, again, the logic takes into account when the platelet count falls, the ratio would increase. Advanced fibrosis is indicated by a value more than 1, and if it is more than 1.5, it is usually indicative of cirrhosis. But this doesn't have a very high positive or negative predictive value, but this can be a useful surrogate if you cannot send for, say, the ELF panel, and in the first go, before the other results are obtained, you can just make use of this APRI to assess to get an overall idea regarding the severity of fibrosis in that patient. Then you have several other scores also. I've told you, I'm not going into the individual scores because, of course, these are being used in certain research and referral centers. But for your practical use, I think FIB4, APRI, and if needed, ELF panel is more than enough. There are others like the BARD, NASH fibro test, NAFLD liver fat score, HEPAMET. All these are non-invasive serum-based biomarker tests to assess the degree of fibrosis. Okay, now we are looking at the imaging-based techniques, mainly ultrasonographic elastography. So the principle of performing this investigation is that you are here to detect the fibrosis in the liver. So when the liver is fibrosed, the texture of the liver gets altered. That means there is solidification of parenchyma. So what will happen to the velocity of the ultrasound waves that is passed by the transducer? Velocity of waves increases because as the density or the solidification increases, the velocity of the ultrasonic waves that is passing through the liver parenchyma also increases. So whatever waves that we are passing through the liver, it gets reflected back at a faster pace. So by looking at the velocity and the time taken to get the reflection back, you will get an idea regarding the liver stiffness. Okay, so by looking at the velocity of the waves, you will get the liver stiffness, which is expressed in kilopascals. So kilopascals is the unit in which the liver stiffness is obtained when the patient undergoes ultrasonographic elastography. And based on the techniques, you have different types of ultrasonographic elastography, like vibration controlled transient elastography, which we call as the fibroscan. Then you have shear wave elastography. Then you have something called as a ARFI, which is acoustic radiation force impulse. Then you have real-time elastography. There are so many types also, but vibration controlled transient elastography or fibroscan or shear wave elastography are the two most commonly performed ultrasonographic elastography methods. Okay, so synonym, we have already learned fibroscan is nothing but the brand name of the company, and the actual method is VCFE, vibration controlled transient, VCT, vibration controlled transient elastography. Now, whom to screen? Should we do a fibroscan in all patients? So the standard guidelines say that when the FIB4 score is more than 1.3, or when the ELF panel score says more than 7.7, or when the APRI shows more than 1, you can consider fibroscan. Okay, so always you go with the non-invasive biomarker-based test first, then you look at the radiological investigation. Okay, imaging-based investigation. And what are the cutoffs that we use? You know, this is how a fibroscan report would look like. I've told you, you get two outputs from a fibroscan. One is the CAP, which is the controlled attenuation parameter, which gives you an idea regarding the steatosis. Then you get the values in the kilopascals, which gives an idea regarding the liver stiffness or fibrosis. We have already learned about the controlled attenuation parameter cutoff. There, more than 240 is what you take as 240 decibel per meter is what you take as steatosis. So here in this patient, the value is only 198. So there is no steatosis. And what about stiffness? You can tell that if the stiffness is less than 8 kilopascals, then no fibrosis. 8 to 12 kilopascals, then it is intermediate, or we are not sure whether there is fibrosis present or not. More than 12 or intermediate, or you can tell there is chance for a fibrosis. More than 12 is definite fibrosis, definite advanced fibrosis. Okay, just like we have learned 3 categories in FIB4 scoring, there are 3 such categories in fibroscan also based on the stiffness measurement. If it is less than 8 kilopascals, no fibrosis. 8 to 12, there is high risk of advanced fibrosis. High risk is there, but if it is more than 12, then definite advanced fibrosis. So this is how you stratify it based on the liver fibroscan. Now, about magnetic resonance elastography, this is the most accurate non-invasive method for staging of fibrosis, and it is superior to all the biomarker based methods and is superior to ultrasound method. So if you are asked which is the best method to assess the fibrosis staging non-invasively, of course, the gold standard would always be histopathology, but non-invasive assessment, the most accurate is the magnetic resonance elastography. Okay, so here, when you subject the patient to the imaging, those areas with low stiffness or low fibrosis would appear as blue. Then slightly high would be green, then yellow, and the areas of highest fibrosis would appear as red. So red color shows the areas with greater stiffness. And what is the cutoff? This kilopascal cutoff is different from that of VCFE or FibroScan. So in FibroScan, we have told you less than 8 is normal, 8 to 12 is high risk of advanced fibrosis, more than 12 is definite advanced fibrosis. Here, even though we are using the same unit, but the cutoff is slightly different. Less than 2.5 is normal, more than 3.6 is advanced fibrosis, and more than 5 is definite cirrhosis. Okay, so the cutoff is slightly lower in magnetic resonance elastography compared to FibroScan or vibration controlled transient elastography. You can see when a patient is having 1.69 coefficient, that means there is no fibrosis. There are no areas of yellow or red. But when as the fibrosis slowly increases, you can see when it is above the cutoff of 2.5, you can see areas of yellow appearing. Then when it is more than 6, you can see there are areas of red. That means higher amount of fibrosis is there. And in very high levels, you have extensive areas of fibrosis as seen as reddish areas. So this is the utility of magnetic resonance elastography, which is the most reliable method. Okay. Then you have scores which combine the imaging and biochemical parameters. So MAST means you have magnetic resonance elastography combined with the AST and is incorporated into a formula to get the final output. Then you have magnetic resonance elastography combined with FIB4 scoring to make into another scoring. So all when you use this combination, it has been found to have a better sensitivity and specificity and predictive value compared to those parameters when used alone. Okay. So this is the summary of what we have learned so far. Okay. So in high risk individuals like those with diabetes, obesity, high cardiometabolic risk, or patients with steatosis or increased AST ALT, what we will do first, we will look at the FIB4 index. Okay, FIB4 index, you can have three outcomes, either less than 1.3, 1.3 to 2.67, or more than 2.67. So more than 2.67 means if the patient is at high risk and there is increased chance for cirrhosis also, then you will refer the patient straight to a gastroenterologist for further evaluation of cirrhosis and its management. If it is less than 1.3, then we are on the safer side. You have to tell the patient that you have to take care of the risk factors and have to follow up every year for repeat FIB4 assessment. And if the patient belongs to intermediate risk category, then you have to look for the next step. In the intermediate risk category means you are not really sure whether the patient is having fibrosis or not having fibrosis. So you have to resort to one more investigation. It could be either an enhanced liver fibrosis blood investigation, or it can be a liver stiffness measurement by elastography, the FibroScan or shear wave elastography. There again, you have the three categories: the low risk, intermediate risk, and high risk. The low risk means the stiffness is less than 8 or the ELF value less than 7.7. That is the two cutoffs that we have learned. Intermediate means the LSM is between 8 to 12 in the FibroScan, and the ELF is between 7.7 to 9.8. And high risk means LSM is more than 12 and ELF is more than 9.8. Both the highest risk is having the greater likelihood of having a cirrhosis, whereas indeterminate risk or intermediate risk also, you cannot be sure whether the patient is having a cirrhosis or not. So that group also should go to the gastroenterologist for further evaluation. So as an endocrinologist, it is my duty to keep the patients at low risk. And if at all they progress from low to indeterminate or intermediate risk, then you should promptly refer the patient to gastroenterologist. Okay. And if there is a delay in referral, you can institute certain measures to control the MASLD, MASH, etc., and which we will be learning in the next slide. Okay, I hope it is clear for you. First, you should know in whom you should perform the screening. Those with diabetes, obesity, transaminitis, and those with the detected steatosis. The first line of screening is always the FIB4 index, which you calculate using the age, platelet count, AST, and ALT. Based on the three categories of the FIB4 that you get, you either classify into low risk, indeterminate, or intermediate, and high risk. High risk will go straight to the gastroenterologist and further evaluation. Okay, low means there is no need for further evaluation, values less than 1.3, and just ask the patient to follow up every year. And in indeterminate risk, you subject the patient to one more test, be it an enhanced liver fibrosis panel or the fibroscan. Fibroscan is more readily available in our area, so we will usually ask the patient to undergo the transient elastography, and based on the value, whether it is less than 8, 8, 12, or more than 12, you will determine the further outcome. Less than 8 means you are on the safer zone, and we can ask the patient to follow up addressing all the metabolic risk factors and diabetes. Okay. Now, this is where the importance of what I have told comes in. So this MASLD is primarily would be identified from the society or from the population by a primary physician or endocrinologist. Only when the diagnosis of advanced fibrosis or MASH has been made, then only the role of gastroenterologist comes in, because no one with a diabetes, just diabetes alone, would go straight to a gastroenterologist for MASH workup. Only when the symptoms set in due to liver disease, they would be seen by a gastroenterologist, and by that time, the advanced fibrosis or cirrhosis may have already set in. So, as a primary physician or endocrinologist, it is our duty to pick up those occult or latent cases of MASH or MASLD, because at such situations, the patient will not be having any overt symptoms, and you have to proactively screen and identify such patients so that we'll have to halt the progression of the disease. Okay. So moving on to management, I'm not going into the intricate details of the management, just we'll be providing the overview of management. The goals in management is obviously to normalize the LFT, to reduce steatohepatitis, and reverse the fibrosis. This is the management goals in the ideal setting, but many a time you may be able to normalize LFT, you may or may not be able to reduce the steatohepatitis, but it is very, very difficult to reverse the fibrosis. Once the fibrosis has set in, the reversal of fibrosis is very, very difficult. So what are the management options that you have? I would say the most effective method, even to reduce or reverse the fibrosis, is weight loss. So weight loss is the most effective intervention to reverse the fibrosis and all the histological parameters as well as the biochemical parameters of MASLD, MASH. So it is said that more than 10% weight loss can in fact reverse the fibrosis in such patients. So weight loss, it can be achieved by your lifestyle intervention, bariatric surgery, drugs, etc. So management options other include pharmacotherapy and bariatric surgery. Bariatric surgery. Okay, so dietary principles, I would say one of the important culprit for this fatty liver is the sweetened beverages. So you have to avoid sweetened beverages. Sweetened beverages, saturated fats, simple carbohydrates, and also you have to ensure calorie deficit. So these three things you should avoid. Sweetened beverages, saturated fats, simple carbohydrates you should avoid and should try to promote calorie deficit. So you should take more of proteins, more of unsaturated or unsaturated fatty acids and complex carbohydrates. So these are the dietary principles that you should follow, and you should ensure for a calorie deficit of 500 to 1000 kilocalorie per day to ensure maximum weight loss. And exercise advice, the standard exercise advice of say 150 minutes per minute of moderate intensity exercise per week is not enough to achieve good amount of weight loss. So you'll have to do over and above that to include more of vigorous intensity exercise and resistance exercise to make sure a meaningful weight loss is obtained. Regarding the drugs, I would just give you an overview. And this is the INASL, that is the Indian National Association for Study of Liver, the Indian guidelines basically. The Indian guidelines advocate three medications for management of MASLD or MASH. They include vitamin E, pioglitazone, and saroglitazar. You know, saroglitazar, it is a dual PPAR alpha and PPAR gamma. PPAR gamma agonist, saroglitazar at a dose of 4 milligrams per day for a duration of 1 year. Pioglitazone at 30 milligram per day for 2 years, and vitamin E at 800 international units per day for 2 years. Okay, so these are the three medications, vitamin E, pioglitazone, and saroglitazar, which has shown some amount of histological improvement when administered to patients with MASLD and MASH. Whereas the American Association for Study of Liver Disease, they also advocate vitamin E, but in individuals without diabetes. The INASL doesn't give that distinction, whereas the American guidelines specifically advocate that it is preferred in patients without diabetes because there is no evidence of improvement of hepatic parameters with vitamin E supplementation in patients who are having type 2 diabetes. Because the trial that has shown the benefit of vitamin E in MASH was the Prevalence trial. Okay, Prevalence trial. And the Prevalence trial was done in non-diabetic individuals, where vitamin E was compared with pioglitazone. So pioglitazone have separate studies of use in diabetic patients, which has shown some improvement in the liver parameters. So vitamin E in non-diabetic patients, pioglitazone definitely. Then the newer anti-diabetic medications like the GLP-1 analogs and the SGLT2 inhibitors have also been shown to have an improvement in the liver parameters. So liraglutide, semaglutide, the co-agonist, the GLP-1 plus GIP agonist, tirzepatide, SGLT2 inhibitors all have shown to reduce the uh, liver parameters, the transaminitis, the liver fat, as well as the steatohepatitis in patients with NASH. Okay, so far the only FDA approved drug for management of NASH is resmetirom. Okay, resmetirom is the only FDA approved drug, and the approval was also given some 2 to 3 months ago. This mechanism is that it is a selective thyroid hormone receptor beta analog. Okay, it is a TR beta analog. You know, thyroid hormone has two receptors, alpha and beta. Alpha is mainly present in the adipose tissue, bones, heart, etc. In the heart, it regulates the heart rate. In the bone, it regulates bone resorption, etc. And the beta is present in the liver and the hypothalamus pituitary region. So when you have a specific agent that binds to the receptor, thyroid hormone receptor in the liver, what all effects do it have? When the TR beta in the liver is stimulated, it would result in the hepatic lipogenesis. It would reduce the VLDL levels. It increases the LDL receptor expression. So the LDL levels would also come down. It reduces lipotoxicity. It increases beta oxidation of fatty acid. and it also improves the bile acid production. So in general, we will get all those beneficial effects of selective TR beta agonism if we are using the resmetirom. So hepatic lipid deposition is reduced and lipid utilization is increased. Beta oxidation occurs and lipogenesis is reduced. VLDL production is reduced. LDL receptor expression of hepatocytes increased. So more LDL would be taken in. And the lipotoxicity effect and the consequent inflammation is also reduced. So all these beneficial effects would be brought in by the TR beta agonism. So the dose is either 80 milligrams or 100 milligrams per day. 100 milligrams per day. And in whom are these drugs approved? In patients with risk of advanced fibrosis or progressive fibrosis. So how do you identify individuals at risk of advanced fibrosis? The liver stiffness measurement more than 8 kilopascal. When you do the fibroelastography, if the stiffness is more than 8 kilopascals, then the patient becomes eligible for resmetirom therapy. It is available as 80 milligram tablet. 80 milligram is given for individuals less than 100 kg body weight, and 100 milligram is given for individuals more than 100 milligram body weight. Okay, this is a nutshell regarding the resmetirom, which is the only FDA approved drug so far. Okay, and drugs with potential use, which has been shown to have some benefit in the clinical trials, but not yet FDA approved. They have lanifibranor, obeticholic acid, which is a farnesoid X receptor agonist. Then pegosafermin. It has also been found to be as good as resmetirom or even better than resmetirom, which is an FGF21 analog. Probably this is also going to get an approval by the FDA in the near future. Then you have survodutide. So again, a very, very effective drug, which has been found to have that impact in the recent clinical trials. Then you have sencriviroc, which is a chemokine receptor inhibitor, where it reduces the inflammation within the hepatocytes. So you have very new and exciting prospects with regards to the pharmacotherapy of NASH. And these two drugs, the pegosafermin and survodutide, has been shown even to reduce the fibrosis or reverse the fibrosis, at least to a certain degree, in patients with NASH and advanced fibrosis. So such is the efficacy of the newer agents like pegosafermin and survodutide. Okay. And the drugs which are not very useful as a pharmacotherapy in NASH, which I have seen being prescribed very widely, but that doesn't hold much benefit in clinical practice with regards to the resolution of hepatic parameters, fibrosis, and steatohepatitis. They include statins. Of course, statins has to be given if the patient requires it for LDL reduction or lipid control. But statins per se will not have a direct impact on the liver parameters. Metformin, ursodeoxycholic acid, I have seen it being prescribed very widely in patients with transaminitis due to NASH, but it has been definitely shown not to have any direct impact on the hepatic parameters. Neither is silimarin. Okay. So there is no point in adding on these things as a supplementation for patients with uh, NASH. So this is what I would do while managing MASLD MASH in our setting. Okay. So first and foremost, you will have to focus on the diet and lifestyle changes to aid weight loss. Because if you are able to achieve more than 10% weight loss, then that itself is enough to reduce and improve the liver parameters in these patients. And then you have to address the risk factors. Like if the patient is having high LDL and cholesterol and triglycerides, you will have to give medications to treat underlying uncorrected hypothyroidism, hypogonadism, growth hormone deficiency, all can worsen NAFLD. So these issues or precipitating factors or risk factors has to be addressed while managing such patients. Then modification of anti-diabetic drug. For example, if the patient is taking insulin, metformin, sulfonylurea, even if the glycemic control is good, even then you will have to add on the medications or replace the existing medications with your current medications which can actually improve the liver parameters like the GLP-1 analogs, SGLT2 inhibitors, and pioglitazone, of course. But you have to be very cautious while using pioglitazone because it can cause weight loss, weight gain, and in elderly females, it can result in osteoporotic fractures, etc. So, in eligible patients, you can definitely give pioglitazone, but I would give preference to GLP-1 analogs and SGLT2 inhibitors, and this should be included in your armamentarium against the diabetes page. And of course, saroglitazar in 4 milligram once daily, at least for 2 to 3 months, would greatly help in reducing the transaminase levels as well as the uh, liver stiffness. And if the patient is non-diabetic, I would also consider addition of vitamin E. So even though the Indian guidelines are advocating vitamin E for both diabetic and non-diabetic patients, the evidence is for only in non-diabetic patients. So this is what all things I would focus while managing a patient with MASLD and MASH. So finally, take-home messages from today's session. I think I have briefly touched upon what is the new change in the nomenclature that has happened, then what is the basic definitions of each of those terminologies, when you should suspect the possibility of MASLD, how to approach a patient with suspected MASLD, and how to confirm, how to look for each part, the steatosis, steatohepatitis, fibrosis, cirrhosis, everything. How can you assess by non-invasive methods by using your biomarkers and radiological investigations, and what are the cutoffs that we are using, and finally, a brief sneak peek into the management aspects as well. So, take home messages finally. All patients with type 2 diabetes, obesity, and raised SGOT, STPT should be screened with FIB4 index to look for the presence of steatosis or steatohepatitis. And a high FIB4 value more than 1.3, it warrants the presence of assessment of liver fibrosis with either a magnetic resonance elastography or fibroscan. And patients with advanced fibrosis should be promptly referred to a gastro specialist for further evaluation for cirrhosis and its complications and further addressing of those issues. And weight loss forms the cornerstone of resolution or reversal of MASH. And of course, you will have to resort to the evidence-based pharmacotherapy to improve the liver parameters in MASLD. So that's it. I hope you have had a good time learning. And this is a very important point, not only for your exams or theory, but this is one of the most overlooked area in primary care practice. As a physician, you don't pay much attention, and this comes into the notice only when the patient has gross liver abnormalities and the cirrhosis has already set in, when there is a little room for improvement. So this is an area where the preventive medicine takes the front seat, where you will have to identify the condition at the earliest and have to institute the preventive measures at as early as possible. So any questions, I'll be happy to take. So if there are no questions, I'll wind up the session. So thank you all for logging in. Thank you.